Hi, I'm Christine, one of the registrars at St. George's. So I'll just be going through a cursory view of the abdominal pain pathways, leaving time for some questions at the end as well. And then my colleagues at Brighton and Evelina will then talk about other aspects. But definitely, if there's any questions, just write them into the chat and I can answer them alongside, or there's definitely time for questions at the end. So the background to all of to why the abdominal pain pathway came into action was because of the GIRF protocol, which is the getting it right the first time, which initiated with the orthopedic teams, where they wanted to standardize care across patients all across England, and that has been translated into pediatric surgery as well, with our colleagues in Liverpool going to different centres to see what was working, what wasn't working, in order to create a pathway that was standardized throughout the country. And in our region, we've taken that pathway and we've adapted it to our region. And it's a very evidence-based, and it is just to ensure that patients get the same standardized care of high quality care for children that have appendicitis across the country, and more specifically for our reasons across this region. So this is what the GIRF protocol looks like. It starts with pre-hospital presentation, whether they present to their GP or they present to ED, and it's if they need a hospital assessment, the GP then refers onwards. This onward referral generally should be done at the local hospital for the initial assessment, even if they are under fives or above fives with abdominal, they should be assessed by their local unit initially. After their initial assessment, if we feel like that they do have appendicitis, then they should get bloods done. And if those are elevated, then they should have a clinical risk score done. I'll talk more about the clinical risk score and what the GIRF protocol recommends us to use. And then based on that, if it's a high risk, then it's either treatment at the local hospital, again, depending on age, or consideration of transfer to a tertiary unit if they're under 5 or with complex needs. The intermediate risk ones, then the first line investigation is an ultrasound scan. And then again, that will give us more answers as to what happens after that. If they are an appendicitis, then they would have the treatment on either, again, at a tertiary centre or at the local hospital. So then you have your non-appendix abdominal pain, and that's if you then assess for appendicitis and felt it doesn't sound like appendicitis, then you either do appropriate management and for whether this is other things, whether that be surgical or medical reasons for why they've got the abdominal pain. And again, the onward referral pathway of whether they need fluids, analgesics, antibiotics, or if they need a surgical procedure, and any onward referral for that. So the first part of the pathway that I'll talk about is the appendicitis score. So there's lots of different appendicitis scores out there. The one that the GIRF protocol wants us to use is the children's appendicitis score. So this is a two-step process. So the first one is looking at sort of the score itself. So there's a coefficient A, which is either 0 or 1. So it's 0 if all the markers are negative, and the markers we're interested in are white cell, percentage of neutrophils, and the CRP. So if it's above 10, if it's above 75% of neutrophil, or the CRP is above 5, if they score any one of those, they get a score of 1. And if all of them are negative, then it's a score of 0. And then that is multiplied by their raw score, which is then weighted based on their symptoms, which are constant pain, right leg fossa pain, pain on percussion or coughing, generalized guarding, a white cell of above 14, which is again different from the score that you want from the coefficient A, and a CRP of above 24, again different from the coefficient A marker of what is a positive marker. And based on that, then you either have your low probability, intermediate, or high probability. If it's less than 1.5, it's unlikely to be appendicitis, and discharge or consider other alternative diagnoses. If it's intermediate, then an ultrasound scan or a CT based on this the study. But obviously with the GIRF, the gold standard is ultrasound scan. And high probability is above or equal to 5. And that's when patients require treatment for their appendicitis. So the first line from GIRF is to have an ultrasound scan, and that is for those with an intermediate score risk or if it is high risk and actually, but there's some diagnostic uncertainty, or a low risk where the symptoms aren't resolving. Again, the first line is ultrasound scan, and children should not be transferred to another hospital for radiological assessment. And that's what GIRFT and our guidelines suggest. Again, practically speaking, there might be some challenges with that, but that is the recommendation, to ensure standardized and equal care and best care for children, so that they're not coming to another hospital however many miles away just to get the imaging done. So transfer guidelines. So at any point in the pathway, if there's any diagnostic uncertainty, then you should consider transfer. But ideally, we'd want these children to have completed sort of the assessment and diagnostic aspects of it before they're transferred. So under fives should be transferred to a tertiary center. And then your above fives, if they have complex needs or any other concerns, they should be transferred to a tertiary center. But otherwise, your fit and well over fives should be managed at the local hospital by the surgical team at the point of when they've been diagnosed, with assistance from the pediatric team. I'll talk more about sort of the MDT approach of the care a bit later on, but I think it's really crucial that the surgeons at the local hospital do get assistance from their pediatric colleagues. Certainly my previous experience working in adult surgery prior to working in pediatric surgery, and speaking to a lot of my colleagues that are adult surgeons, a lot of the fear that you get from treating children is just they don't know how to take care of children. So having that pediatric support is really helpful, whether that be, recognizing an unwell pediatric child with prescribing. That is all really helpful to a surgeon, and it could make referrals, I suppose, where the challenges are, referrals to with the above fives to your general surgery colleagues at your hospital a bit easier if you're saying that actually we'll support you with this, and providing assistance in the pediatric aspects of it, because the surgery bit it's fine. They can manage that just fine in the above fives, and certainly some of them feel confident in the below fives as well. But the main bit that they struggle with is actually the medical sides of it. So certainly studies have shown that with good pediatric and surgical care, that does show that that the children are getting really good care with the joint efforts with the MDT approach. So in terms of the management, once you've got to the diagnosis, once the diagnosis is certain that we've got appendicitis, the antibiotics should be given within the first hour, as well as ensuring that they've got adequate analgesia as per the WHO pain ladder, as well as IV fluids. The antibiotics can be as per local guidelines, and certainly the fluids should be sort of as they're tolerating, and ensuring that they're appropriately fluid resuscitated, because that's really important to the care of appendicitis. That a lot of it is ensuring that they've got adequate resuscitation and the antibiotics are started, and that's sort of the main, getting it within that first hour is very good for their onward progression. The GIRFT protocol states that they want us to have the operation within 24 hours of diagnosis. Within the SDPN, we're still aiming for 12 hours, and that is certainly the recommendation from different studies that operating within the first 12 hours is better for outcomes. And then in terms of what the guideline says about complex appendicitis, they should have antibiotics for at least 72 hours from diagnosis, depending on whenever they get their operation, with at least 48 hours of that being IV antibiotics, and then they can switch to oral after that. And they may need longer. Again, that's based on clinical assessments and how the patient is doing. So a big part of this is also the assessment responsibility and sort of who takes care of the child, and I think there's a lot of contention about that. The pathway does state that when there's a primary care referral, it should be assessed at the local pediatric center first, rather than at the specialist center, regardless of what age they are at. In non-specialist centers, the pediatricians should lead the clinical decisions for care less than 5, and very much should request their local surgical services. Again, obviously there is difficulty in getting that because sometimes the general surgeons feel like they can't manage the under 5, but where you can get the general surgeons to come, we'd certainly recommend trying to get them to come, because with a joint decision making, that is certainly better for the children. And then if they and the above fives, again, after the assessments and in terms of their care, that should be referred to the general surgeons. But again, the pediatricians should be helping them with their with the care of the children, as they don't routinely take care of children. So so they would, I'm sure they would greatly appreciate pediatric input when they take care of the above 5 appendicitis patients. So as Laura mentioned, we did do an audit of how our region has been doing with the implementation of the guidelines, and it does show that we're good at managing appendicitis at specialist and non-specialist centers. We have a reducing number of negative appendicectomy rates, which is one of the main goals of the GIRF protocol. And we are very good at actually managing these patients within our center and not actually and it's very uncommon for patients to be transferred outside of the guidelines. So that's sort of the overall pathway and what the pathway should be. And I just thought I'd just run through some 2 quick cases just to sort of solidify the pathway. So this first case is an 8-year-old girl with a 2-day history of abdominal pain that's centrally located. All these patients, before they go down this pathway, should have a urine dip as well. And so her urine dip is negative. She's come with a temperature of 38, a white cell of 12, neutrophils of 5, and a CRP of 20, because we think that it is appendicitis, and so she's had these bloods done. So talking through the pathway, we think that she is likely appendicitis. We've done the bloods. So the next step is the clinical risk score. If anyone wants to sort of talk through how they would do the clinical risk score, either talk or chat if you don't want to have your voice heard.
Please be brave and join in. Doesn't matter if you don't get it right.
Okay, so no volunteers, so I'll just go through it anyway. So the coefficient scores 1 because she has got the white cells and the CRP that are raised. So that makes, even if either one of those were raised, then she would score a raw score of 1. However, when you look at her actual raw score, we'll say that she's got this constant pain that's centrally located. That scores a 1, and her white cell and CRP don't meet the threshold for any other of the weightage. So she actually scores a score of 1, and therefore she's low risk and would be discharged or consider other diagnoses in her case. Fine. So a second case, so a 4-year-old boy with a 1-day history of generalized abdominal pain, again has had a urine dip that is negative, and a CRP of only 5, but a white cell of 24 and a neutrophil of 11. So again, we think it's likely appendicitis. But what do we think the CAS score is? And just for the clinical aspects of it, they are still in constant pain. It hasn't localized to the right iliac fossa. There's no pain on percussion or coughing or guarding. So any comments on what we think the CAS score is?
Somebody have a go. Pop your microphones on or pop it in the chat.
There's things, someone's put scores 1 on coefficient A and 2.
So for the most,
we're getting a real mix here.
So for case 2, it was 2.5 or 2.5.
Yeah, brilliant.
2.5, yeah.
Yeah, so they would have scored for the white cells going 1.5 and the constant pain of 1, so that's 2.5, and so that would be an intermediate risk score, which would be an ultrasound scan. So this child had an ultrasound scan and it did show signs of appendicitis. So With that, you would start IV fluids, analgesia, and antibiotics within the first hour of when you've diagnosed it, and that includes giving the antibiotics and all the treatment within that hour as well. The thing with this case is that obviously they're an under 4, and so this patient would need to have their operation, or we would consider their transfer to a tertiary unit. And the important thing in that GIRF is that it's at any point in the assessment and diagnosis to consider that referral to a tertiary unit. Again, ideally, this patient, ideally, if you can get all the diagnostics done prior to transfer, that would be the best case for the child, especially if you've assessed that there's an intermediate one, and getting the ultrasound scan would be really helpful. And if it did show an appendicitis, then they should be transferred to a tertiary unit. But I think that does present some challenges at some of our non-specialist centres. But the GIRF protocol does want children to get the ultrasound scan at their local centre. So for the transfer to tertiary unit, it will be a discussion with the pediatric surgery team. Would still, even if they're under 5, would consider a general surgery review, especially again if they're unwell and thinking that they need surgical opinion sooner, where they can't come over to the pediatric surgery unit because of bed situations, etc. And the pediatrician should lead that care up until their referral to the tertiary unit, and utilize a stop tool in order to allow for safe transfer of the child, which my colleague will talk about in more detail later this morning. So that's me in terms of my presenting, but if there's any questions, I'm happy to take anything.